Hi, good evening everyone. This is Roaa Khalil, hematologist in King Fahd General Hospital, Jeddah, Saudi Arabia. And today I'm here to present the outcomes of adolescents and young adults with Philadelphia negative ALL utilizing pediatrics versus adult treatment. This is the list of the authors whom we worked together. So, ALL. All of us know that ALL is the most common hematological malignancies in children with a very good survival rate reaching up to 90%. However, it tends to have an inferior outcome in the adolescents group with a very poor and aggressive course. There is several studies done showing an efficacious and beneficious outcome in treating those group with pediatrics regimen. Therefore, our team decided to do this multi-center retrospective study to compare the outcomes of adolescents and young adults with Philadelphia negative ALL treated with modified pediatric regimen, specifically the augmented BFM, versus the adult hyper-CVAD regimen. Patients aged 14 to 40 years were enrolled from King Abdulaziz Medical City, Jeddah and Riyadh through the period from 2010 till 2022. This table showed the baseline characteristics between both groups. Total 103 patients were enrolled. Patient demographics were similar between both groups. However, there was some differences in the treatment protocol. For example, rituximab was used in the augmented BFM arm regardless of the CD20 status. On the other hand, it was used only in the hyper-CVAD if they have CD20 positive. Also, the blina was used in the augmented BFM if they tend to have MRD persistence as per the protocol. However, none of the patients in the hyper-CVAD received it. Now we will compare the outcomes between both groups. We can see that the MRD positivity after consolidation, there was a statistical significant difference with 26% in the hyper-CVAD versus 10% only in the augmented BFM. Also, there was a significant higher relapse rate with the hyper-CVAD in compared to the augmented BFM. Also, the incidence of death was higher in the hyper-CVAD in compared to the augmented BFM. And that's definitely lead to lower patients went into hematopoietic stem cell transplant in the augmented BFM. So our results showed at 5 years follow-up, there was a statistically significant superior overall survival and disease-free survival using the augmented BFM in compared to the hyper-CVAD. Also, if we looked at the curve on the right side, we can see that at 3-year follow-up, the difference between both groups were comparable. However, after that, at 5 years, the difference was clear. So in terms of toxicity, interestingly, there was no difference in prolonged neutropenia and thrombocytopenia between both arms, keeping that the hyper-CVAD is a myeloablative regimen. The incidence of liver toxicity was significantly higher in the augmented BFM, and that's definitely because of the asparaginase used. Incidence of pancreatitis was only noted in the BFM. None of the patients in the hyper-CVAD developed it, but that was not statistically significant. The rate of death was defined as having disease relapse or died from sepsis, and we can see that 24% of the hyper-CVAD died from disease progression, with only 3% in the augmented BFM. That was as well statistically significant. So in conclusion, our study demonstrated a superior outcome using the modified augmented BFM protocol with better overall survival, disease-free survival, and lower relapse rate. Certainly, more studies are needed to accurately compare the different protocols and to improve the outcomes. Acknowledged to King Abdullah Medical Research Center and King Abdulaziz Medical City. Thank you.
Thanks, Roaa.